I'm Lucy Mudie. I'm an ophthalmology resident at the University of Colorado. As residents, we deliver eye care to patients at multiple hospitals in Denver, Colorado. One of these hospitals is Denver Health. It is a large tertiary hospital in downtown Denver. Denver Health is a safety net hospital, meaning that it is mandated to take care of all patients regardless of their ability to pay. Denver Health has been aiming to provide high-quality, cost-effective care for all Denver residents for more than 150 years. Through its mission to provide care for all, Denver Health needs to be able to take care of even the most vulnerable patients in a cost-effective way. The hospital is consistently recognized as a healthcare leader by the Human Rights Campaign. In 2018, Denver Health saw almost 1 million patient visits. Of these, 460,000 were visits by Hispanic patients, 271,000 were visits by white or Caucasian patients, and 140,000 were visits by African American patients. It has long been known that racial and ethnic disparities exist in access to medical care. The Agency for Healthcare Research and Quality reports annually on healthcare disparities. The latest available report from 2018 showed that Hispanics received worse care than whites for about 35% of quality measures. Fortunately, over the past 2 decades, disparities have improved for some measures. Among the many reasons for disparities in healthcare, communication barriers secondary to limited English proficiency are high on the list. Language barriers can lead to poor understanding of diagnoses, poor treatment compliance, poor alliance between the patient and provider, and suboptimal care with poorer health outcomes. We know from prior studies of emergency room visits that patients who don't speak English are 24% more likely to have an unplanned second ER visit within 3 days. And in one study, the average cost of an ER visit was around $40 more for non-English speakers. However, if the ER physician treating the patient was bilingual, the cost actually went down by just under $100. Thus, the challenge for providers working in a hospital such as Denver Health is to effectively and efficiently deliver the same care regardless of our patient's primary language spoken. Certified interpreters have been suggested as a way to overcome language barriers. However, their use varies wildly, from 16 to 71% in one study. Often this is due to a lack of availability, real or perceived time constraints, or a lack of training in the use of interpreters. In order to improve the quality and cost-effectiveness of care received by ophthalmology patients at our diverse safety net hospital, we undertook a retrospective review of data from patients' visits to the Denver Health Eye Clinic over the past 4 years. We analyzed data from our electronic medical record to try and understand how care delivery differed by various patient or encounter features. We found that of the 165,000 visits to our eye clinic in the past 4 years, the majority spoke English as a first language, while around 1/4 were primarily Spanish-speaking, with the other major languages spoken being Arabic, Amharic, Vietnamese, Russian, French, Nepali, and Tigrinya. Around 28% of our total visits required an interpreter. For Spanish speakers, around 79% of visits required an interpreter, and this was similar for our other non-English speakers, with the exception of Amharic and French. The average age of visit was around 47 to 50 years old for both English speakers and non-English speakers, fairly typical for an ophthalmology clinic. The average time spent with physician was similar among all patients by language spoken. This is concerning since we would expect the language barrier to require more time for translation if the same care is being delivered. However, when we look at time spent with nursing staff, there is more time taken with non-English speaking patients, and this may be due to the fact that nursing staff are required to collect more history from patients than physicians. It's also reassuring for our quality of care. We found that non-English speakers spend more time waiting for their doctor than English speakers. One possible explanation for this is a bias whereby physicians prioritize a patient visit they perceive will be quicker. We found that total time in room was the same whether the patient needed an interpreter or not. There may be several reasons for this which we are still trying to understand. However, it again raises the concern that the same care is not being delivered when an interpreter is used. Interestingly, although limited English proficiency may be a barrier to care, we found that non-English speaking patients are more likely to keep an appointment once they make it. Although the appointment length did not vary, it does seem that physicians are aware that different modes of communication may be needed for non-English speaking patients. We found that non-English speakers were more likely to receive their printed after-visit summary with written instructions. Our study has many limitations, and these overall metrics do not provide fine detail. However, they do smooth out variability between providers, style of practice, and workflow. Our data is a jumping-off point for eye care doctors and administrators. As the non-English speaking population of the United States is expected to grow, transforming our practices to deliver eye care effectively and efficiently across language barriers is an essential investment in our future.